And in the last 40 years or so that I've been in practice, I've been a witness of those deaths. They are sad because they are preventable. From the oncology side, the cancer side, we're also aware of how much interruption takes place in the treatment of a cancer patient when there is no blood. You cannot put them on radiotherapy. You cannot put them on chemotherapy because their blood levels are too low. And when that blood is not there, you cannot continue the treatment, you interrupt the treatment. So blood is really the blood of the practice of medicine. And it straddles the whole spectrum of healthcare, from primary healthcare to the highest level of tertiary healthcare level. At the no talk about shortage here. Blood. Anywhere where there's human beings who are walking and alive, there is blood. So this is a commodity that is not in short availability. It is in people. The question is, how do you get it out of those people and put it in the next person? The same thing, almost similar, will be in other areas of transplantation. That oftentimes is not that the organ is not there. They are there in people, but you've got to get it out of somebody else to put it into another person. Herein lies the enigma and the problems of blood and transplantation. Because it is with us in plenty, but we have not worked ways in which to make it utilizable. Probably one of the most difficult things to carry with you and transport is human tissue. And blood is part of that human tissue. It is easier to kidnap a live human being, even one who is unconscious, and cross the border with that person than it is to cross the border with the tissue of a human being. It is easier for you to move a patient from Kenyatta to Nairobi Hospital or vice versa and cross Mbong Road than it is to move tissue across there. And I can recall that that tissue doesn't have to be just live human tissue, but even dead ones too. Those of you who are as old as me, Professor Muga, you're here, you'll remember the stories given by our late professor of anatomy, Professor Joseph Mungai, when we were starting the medical school here in Nairobi. At that time, we did not have laws that governed the use of human cadaver, human body. And to start that school, he had to carry a dead body from Makerere in his black VW Beetle across the border to Nairobi for the first students to be able to start dissecting a human being. And the story is both funny and tragic, because when you reach the border with a dead body in your car, it's more difficult to pass than if there was an unconscious person in that particular car. This brings in the issues then of laws and regulations. Governance becomes the first area that one needs to look at this. If we are going to turn the plentiness, the bountiness of blood in all of us and other organs in all of us into things that can be used by the next person, because they become both emotive, legal, and our regulatory systems at the moment do not cover the full spectrum of what can happen there. I'm not saying that you need more regulations. What I'm saying is that the regulations must be more facilitative without being unethical. Now, the topic that my team here will be discussing with you is about sustainability of blood transfusion systems and transplantation. The key word there for me is sustainability, because the rest of the 2 days you'll be discussing all the technical issues around them. The question is sustainability. In the many years that I've worked in this field, one of the most interesting one was Africa-wide, looking at where the World Bank was investing. And the biggest recent investment in blood transfusion services in Africa came because of HIV/AIDS. The PEPFAR program and the World Bank program. And they saw over 20 years the building of massive infrastructure to make safe blood available for Africa. Nothing like that had happened, not since the time of the World War. Those of you who don't remember, the African introduction to blood transfusion came during the Second World War, because the British soldiers and German soldiers needed blood. It forced them to accept that even the African blood was blood. And they started finding ways of collecting blood. That collection was often done mandatorily without consent. And that experience of being forced to be bled, the Maasai do with their cows, is what has basically led to the fear that people have had in the removal of blood.
Blood services is one area where we have achieved tremendous progress in terms of being able to increase access and availability of blood products in the country. We have achieved in making substantial investment in one, repairing our equipment that had broken down. We have replaced some of our very old equipment that basically was outdated even in terms of technology and was not functional. So we have revamped the whole infrastructure of blood services in the country. We have availed investment to ensure that at any given time we have a clear process is one area.
These blood banks and blood institutions around Africa, I have gone back and seen them almost closing. Big, expensive machinery, fridges, and name it, because our countries never budgeted for blood. So the issue of budgeting and financing then becomes as big a factor in the discussion that you must have as that one of law and regulation that you will be having. Financing. How do we finance blood transfusion and transplantation services? The mistake that we often make is that we discuss these things vertically. And we then come up with a donor-supported vertical growth that we know will not be sustainable. So the question that must be asked is, to what extent have we integrated these services into the health systems that we are building? And much, much so, is it a discussion that the many UHC conferences that we have undertake? Is blood ever raised and discussed in UHC conferences? If not, why not? But if it is, then let us start looking at the health systems that need to be strengthened in order for us to have sustainable transfusion services. First is the one of governance, and Eva Njenga is here and will be asked and will explain to you what the law says and cannot say. But even more important is what the law not only must say, but must ensure that is enacted and it is enforced. Because the moment you talk about blood and other human tissues, the issue of access and equity come in. How come when I go to Nairobi Hospital and I need surgery, blood is always available on the morning of surgery? But when I go to Kenyatta, blood is not available in the morning of surgery. Is these hospitals using the same source? If it is the same source, then how come some hospitals get it faster than the others? What do they use to make sure that at Nairobi Hospital I have my blood and not at Kenyatta? So the issues of regulation must be there and must look at the issues of equity. And regulation must also start looking at the issue of possible sales or illicit sales. Blood is a tissue, kidney is a tissue, and they must be treated similarly. So when somebody is selling a kidney, they must not be seen to be more sinful than the person who's selling blood. They are both tissues. Second area that we must look at after governance is the area of infrastructure. As I mentioned, PEPFAR programs, USAID, World Bank have put up enormous infrastructure. Regional blood banks, regional this and that. But the question is that, will we be able to sustain and improve on them? What is the budget that's going to take over the running of this place? If it's not there, then that's a lost cause, and sustainability is not there. Third is the area of logistics. Blood could be seen as a commodity, albeit one that does not come from a shop, but comes from another human being. So the inefficiencies of commodity logistics in this country that we have witnessed so openly in KEMSA will hit us with blood too, because it is stored somewhere and it has to move somewhere. But not only that, the processing of safe blood relies on the efficiencies of the KEMSAs of this country. Because you need the reagents, you need the bags, you need everything that goes in it. And how often have you been there with donors, but the bags are missing? How often have you been there with blood, but you can't group it, or you can't test and screen it? If that is not working, the sustainability is not with us at all. Fourth, and related to that, we've talked about governance, we've talked about financing, and we've talked about the logistics and the commodity movement on that. Must be the area of data. Data and technology come in together. And there is no area where digital technology can make a bigger difference than in blood and transplantation services. It requires speed, it requires accuracy, it requires focus and targeting. So far, we have talked of technology in this area in terms of how to carry it through drones and so on. That's not it. This country was moving forward towards biometric identification. I want to believe that biometric identification would include one's blood group. Suppose that was happening and every Kenyan had a biometric identifier and we knew the blood groups of these people. How could we in the health sector use that to effectively source blood when it is needed? Because we know where the O positives are, we know how the O negatives are, and so on. What conversation should take place under those circumstances for us to be able to move forward? Fifth is the service itself. Blood transfusion and transplantation. At what level should it be? Should it be a specialized service? Definitely the ones that require high skills must be. But how low can you go in terms of giving blood transfusion? Primary care level? Why not? These have to be discussed so that this commodity is not being used. Finally, is a human resource. Unfortunately, blood transfusion and transplantation services in this part of the world has been seen more from the medical standpoint. So a lot of capacity building and training has focused on the doctors and the nurses and the laboratory people who are there. But I want to put it to you that this is a science. And it's a science that requires more non-medical people than medical people. And if we are going to make the best use of our resources, then we must start asking what are the kinds of training and institutions that we must build out there to bring the capacities into these areas. It's not just about doctors. It is more than that. It is within that context that I'll make my last remark. That, as I've said, tissues are in plenty because it is ours. I'm made of tissue. You can get any tissue from me. The question is that how do you convince me to give you to use it? But the sad thing that I've observed too in the continent has been the vast wastage of blood. We collect blood, we don't use it, we throw it away after 2 weeks. Because we don't know how to fractionate or don't have the capacity to use the different parts of blood. For so long as that capacity is not in, we shall be using all blood wrongly and therefore wasting it, or not being able to take the plasmas and so on to store for use, we are throwing them. You all know, those of you who have worked in the services that I've worked in, how much blood we cast away 2 weeks after a major national drive because we couldn't use it within that time and so on. This means that there must be a paradigm shift in the way we solicit and collect blood, in the way we process it and store it, in the way we distribute it, in the way the individual source it. It must not be to the one in the most expensive hospital before the one in the lowest hospital. And most important, in the way in which we sustain these services. I could have spoken more, but I'm told that I'm already out of time. Thank you very much.
Thank you, Prof, for that wonderful opening presentation. And what I've picked for your presentation is that blood transfusion is a science beyond doctors. Moving on to our next presentation, Professor Walter Mwanda. He'll present on national standards for blood transfusion service. Prof, with all due respect, and for the interest of time, you have 10 minutes. Thank you.
Good morning, everybody. Yes, my dear colleagues, I'll be fast as usual. I have 2 slides. I just want us to go through why we need, my colleague, avenues, we need the standards, so that things are done in a particular way. But more importantly, we would not want somebody to come from here to the camp or from Scotland to here, fearing that our blood, fearing that blood is adequate, fearing that he or she gets an accident, may not be fused. That is the basis of the standard. Keywords will be the standards and the National Blood Transfusion Service. Basically, I'll give a background, give issues regarding the standards, blood and blood components, scope, application of standards, national blood transfusion, usage of terms, and a few references. The national standards on blood transfusion aim is to provide an equitable, high-quality level of care for the people receiving transfusion, irrespective of the healthcare setting in which that transfusion is provided. My colleague did mention, where should we start? Wherever we start, be it a primary, a health center, level 5, level 6, private institution should have one standard. Ensure a uniform system for records management. It's only through that that we'll know what is going on. Facilitate both internal and external monitoring and evaluation. If you can't monitor anything, you better not start it, because you just go wrong. Safeguard public health and ensure quality in the provision of care to all patients. In the context of blood transfusion, the standards are a set of criteria to guide all processes and guide all those involved in the provision of health care. It is to ensure that the care provided to the patient is of the highest quality. Of course, the basis of giving that blood is to save life. And the other gain in medicine is premium nano-seal. If you can do nothing, a safety net against errors who to establish standards, you need experts in the field. And those experts must carry out wide consultation involving the stakeholders. They must also be evidence-based. And that is where we come from. That is what my colleague talked about. Evidence-based means that is homegrown evidence. Evidence-based means those who are practicing. Evidence-based means those who are donating. And those standards must impact on the entire service and patient care must be carefully evaluated prior to adoption and application. That is key in blood transfusion. Indeed, the standards here must be the standards in Brisbane, Australia, must be the standard in Southern Sudan, must be standard in Marrakesh, Morocco. There must only be one, but must be adapted and applied. Blood and blood components, they are given voluntarily, and use as intended is life-saving. They enable treatment that would otherwise be impossible. However, for every good thing, there must always be an issue. May morbidity and even mortality through severe adverse events and reactions. Errors should be eliminated as far as possible. Patients should not be exposed to transfusion unless necessary. Blood be used appropriately and effectively for the ultimate benefit of all patients. The standards should be scoped to impact on every activity in the system of blood transfusion practice. The scope of standards must be well described and put by every player and every citizen. Cover blood transfusion practice in adults, in pediatrics, neonatal setting, in primary care, and acute care. Specialized care settings, as my colleagues talked about, in obstetrics gynecology, in cancer management, in hemophilia management, in sickle cell management. Application of standards are affirmed by the following statements. All service providers, irrespective of where they are, public, private, or both. All healthcare establishments, all healthcare professionals who prescribe blood, transfuse blood, all blood components. However, much in line with the course of professional and institutional ethics of the respective professions. In other words, if you're a doctor, you must practice what is required of you. If you're a nurse, you must practice what is required of you. If you're a dentist, same. National standards for blood transfusion service objective, however, remains maintain and enhance the quality and safety of blood transfusion in health facilities. Areas of standards starts from the donor and ends transfusion. All areas must have the standards, not leaving out the equipment. The current scenario, and I hope the doctor is here, in most countries in Africa particularly, a supply system in the country functions as a part of the laboratory services in all the hospitals, whereby individual hospital bank is obliged and responsible to undertake the task of recruitment of donors, collection, screening, infection, storage, and making it available for transfusion to the clinic areas. This is a fragmentation that requires system so that the standards can work. A national standard must assume a consolidation of services in one system, and that is the National Blood Transfusion Service. The standards should be based on the way the organization and the functional structure of the National Blood Transfusion Service that should enable the following: provide the best possible care to the donor before and after donation. Ensure that best use of donated blood is made by the prescribers. implementation of a quality management system in the service. Standards are suitably applied in an organized structure